From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Cardiology Author Interviews. Thanks for joining us. I'm your host, Dr. Kristen Patton. I'm a professor of medicine and electrophysiology at the University of Washington and an associate editor for JAMA Cardiology. I'd like to welcome today's guests, Dr. Al Buxton, a professor of medicine and cardiac electrophysiology, and Dr. Marie-France Poulin, an assistant professor in interventional cardiology. They're both at the Beth Israel Deaconess Medical Center in Boston. Welcome to you both.
Thank you.
And today we're going to be discussing their work on the mechanisms of conduction block after TAVR. Al, to get us started, can you tell us a little bit about how your collaboration happened and how you all decided to pursue this project?
Well, we've been frustrated by a lack of clear understanding of when to insert pacemakers, when to monitor patients that are undergoing TAVR. As you know, conduction disturbances following TAVR are quite frequent. And while there are guidelines that have been published, many of them are not based on large-scale studies. So we thought it would be worthwhile conducting a prospective study in order to continuously record both intracardiac electrograms and monitoring several surface ECG leads throughout the TAVR procedure in order to better understand just when conduction disturbances during the TAVR occur, as well as what type of conduction disturbances occur.
It's an amazing study, and I think the cross-collaborative nature is striking and probably a reason for its success and the applicability. Marie-France, can you tell us a little bit about the design of the study and how you guys conducted it?
Sure. So we wanted to be able to enroll all of our patients, all comers, except for the patients who had a prior pacemaker, to try to really find, who would develop a block, who they would be, and which characteristics they would have. So all of our patients who were coming in for a TAVR were approached to be part of the trial unless they actually refused or had a prior pacemaker. And with that, we actually had a lot of fun doing this study with Dr. Buxton, where I relearned how to do an EP study, a proper EP study. And with that, we were able to gather a lot of information that we couldn't have otherwise gathered.
So great. Super important information. And Al, if you could just tell us what you think are a couple of the most important findings.
Well, the things that impressed us most were that although most assumptions have been based on the His bundle and the specialized conducting system as being the source of conduction blocks, we actually found that a small percent of patients develop both intra-procedural block as well as post-procedural block that we could localize to the AV node. This was clearly a minority of cases, but there are clearly patients in whom presumably the anatomy of the AV node is very close to the membranous septum and therefore can be affected by placement of a transcutaneous aortic valve. That was the first interesting finding because that, I don't believe, has been clearly documented before. The second finding was we confirmed what I think most operators know, that pre-existing right bundle branch block carries a high risk for intraprocedural block. We found that about 13% of our patients entering the trial had a pre-existing right bundle branch block, and almost 20% of these patients developed block during the TAVR procedure. The third thing that I would consider a major finding is that factors that are associated with development of block during the procedure seem to differ from the factors that were associated with block following the procedure. Most prior studies have divided block into block during the procedure and block after discharge. And the problem is that the durations of hospitalization and therefore the time of discharge after the procedure vary. And it's not been clear just exactly what is going on during the procedure? Is that different from what's happening with regard to the conduction system after the procedure? I think what was different about our study is that we found that by classifying the blocks that occurred during the TAVR seemed to behave very differently than patients with block that developed after the procedure. I can elaborate on that a bit if you like.
That would be great. I think this is one of the most fundamentally novel and interesting parts of your findings is the differences in outcomes between patients having block during the procedure and block that was delayed. So I would love to have you elaborate.
Okay. So whereas right bundle branch block was clearly the most important pre-existing risk factor for intra-procedural block, pre-existing right bundle branch block did not predict block that began after the valve implant. During the procedure, the development of left bundle branch block did correlate with intraprocedural block, but it did not predict, or we didn't find an association of new left bundle branch block that appeared either during or after the valve placement. It did not correlate with delayed block. The nature of block that occurred during the procedure differed from the block that appeared after. All 15 patients that developed block during the procedure had persistent block. It was not episodes of paroxysmal block, but they developed persistent block. And in fact, when we examined the percent of pacing in these patients at both 30 days and at 1 year, those patients had, on average, over 90% need for persistent pacing. In contrast, 80% of the patients in whom block developed after the procedure, the block was paroxysmal. They had brief periods of complete heart block, or in a couple of cases, Mobitz 2 block, or in a couple of other cases, episodes of block went on for up to 11 hours, but it wasn't persistent block. It was block on, then resumption of normal conduction. And when we looked at pacing in these patients at 30 days and at 1 year, those patients with delayed block were pacing less than 10% median at both 30 days and 1 year. So the fundamental nature of block seems to be different when it develops during the procedure versus block developing after the procedure. We were concerned that maybe the pacemakers were programmed differently for patients in whom block developed during the procedure versus after the procedure, but we made great efforts to program the lower rate as low as reasonable, and there was no difference in the lower rate that was programmed for the patients that developed intraprocedural versus delayed block. And the other thing that can obviously affect how much pacing we observed is how do you program the AV delays? And we program those delays not with the out-of-the-box values, but as long as possible in order to minimize pacing. And we found no difference in how the patients who had developed block during the procedure versus after, how the AV delays were programmed.
So much critical and important information. And I think I just really want to highlight this issue of both the presentation of intraprocedural block versus delayed block, and the ultimate outcomes are very different. And this definitely raises some questions about how we start thinking about risk prediction in these different populations, right?
Exactly.
I want to go back, Marie-France, if you could tell us a little bit about the procedural aspects of these patients that you saw, what kind of valves you put in, the valve-in-valve patients. It would be great to have a few details to put this into more context.
Sure. So our TAVR population was a very typical patient population for who usually undergo TAVR procedures. Mean age was 78. And we are a center where 90% of our cases are done with balloon expandable valves. And we had Was it 10%? What's the percentage of valve and valve?
10% of the valves were the self-expanding valves, and of the 409 patients, 34 were valve and valve procedures.
Correct. So yes, 90% of our cases were balloon expandable valve and 10% were self-expandable. And there were a total of 34 patients who were valve and valve cases. And we thought it was important to include them in this analysis since some of them do still have heart block, even though the risk is lower, it's not zero. And actually, we did have a patient who did have a heart block after a valve and valve procedure. So again, trying to understand the exact mechanism of how this happened is very important for us clinically.
I totally agree. I think this was an issue that came up when we discussed the paper in our editor group, that some of us had not experienced much in the way of heart block in the valve and valve patient population. And in my clinical experience, we actually do see it. So I was concerned about that risk. So I thought it was great that you included those patients as well.
So you've seen it too, Kristen.
Yes. Yes. And I wonder too, I don't know if Marie-France, you can speculate at all about some of the mechanisms why we see it sometimes in other, if it's fracturing the previous valve or anything that we do mechanistically or procedurally that will increase that risk for those patients.
I do think some of it is inflammation or irritation, right, of the conduction system, just from maybe having the balloon expendable or the tip of the valve touch it transiently. So I think some of it could be just kind of a shock or irritation to the conduction system during the procedure, but some of it is a mechanical compression factor as well. So when the valve, if the membranous septum is shorter and the valve does end up, compressing it, then I think the risk of block is higher.
Makes so much sense. And Al, I want to go back to something that you mentioned previously, because I think so much of the literature in this area is really confounded by how we program pacemakers in these patients. And so often, as you said, we put pacemakers in patients who have conduction abnormalities of all types after TAVR because we're worried about them. And then we program their pacemakers in standard fashion, and then they're pacing all the time, and we pat ourselves on the back because we think that we've done good for the patient until they develop their heart failure. And it sounds like you did not do that in this case. And I just love that about the pacemaker programming. And I wonder, did you think about this early and pre-specify the programming, or is it just a hallmark of your excellent electrophysiology care that patients had prolonged AV delays and so on?
Every patient in whom we place a pacemaker, we try and think about how we program both the lower rate and the AV delays to minimize unnecessary pacing. So it was critical. When you look at the literature, I don't think there are any papers that specify how did they program their pacemakers. So it's very difficult to interpret how necessary are they. And so this was one of the features that we prospectively incorporated into the design of this study.
And Marie-France, I know the structural team placed the EP catheters. Was it incredibly helpful to have an electrophysiologist there during the procedure? Or is this one of those things over time that if it became just part of the regular clinical case, that would be fine for the structural heart team to be doing? Or do you think that there's always needs to be really close coordination between EP and interventional in these cases?
Yeah, that's a great question. So the catheter manipulation, it took a few cases for us to know where to ideally place the catheters. The, high RA was easy, but finding the AV node, the His bundle was a little bit more challenging initially. Then we developed some tricks. And then in the end, I think we got pretty good at it. Also, we refined the position. So we've been using the His catheter also for rapid pacing during the valve deployment. So at the beginning, we were putting it like we're used to for a balloon-tipped catheter at the tip of the apex. But we found out that it was not an optimal position for two reasons. One is it seemed to be less stable. So we had higher thresholds, sometimes loss of capture during the rapid pacing tests. But also we were using octapolars for most of our cases. We thought these were the ones that worked the best for us. It was a little deeper, so it did not allow us to get an intra-His recording as well. So once we, trialed all of that, and now we've actually, we've ended up publishing this. There's a step-by-step of how to do this. The catheter manipulation, I think, most interventional cardiologists and our cardiac surgeons too were part of this, should be able to do this. It's the interpretation of the electrocardiogram, right? The His bundle that
Yes.
I think
Yes.
there's a lot of benefit of having an electrophysiologist present. With training, I'm sure that everyone can learn and it could be incorporated into our practice. But we certainly learned a lot and always benefited from having the experience of Dr. Buxton there.
This is just such great work, and I'm really excited to hear more in-depth data about the EP study results and so on and so forth. I just want to make sure before we finish that I'm not missing any great take-home messages for our audience that you guys wanted to provide.
I would say Marie-France and the other interventional structural cardiologists, the recording of the HIS and the entire EP study we looked at, and they estimated that it prolonged the procedure by only about 5 minutes. As she said, there was a learning curve, but it wasn't terribly steep. The biggest limitation probably to incorporating these studies routinely is the fact that in our cath lab, and I suspect in most others, the amplifiers that are used to record an EKG and pressures are not equipped to record intracardiac electrograms. I'm sure that such amplifiers could easily be placed, but there are obviously monetary considerations that may limit. The other thing that limits, although this was very useful, I think, in identifying sites of block and to some extent identifying associations with delayed block, one of the most frustrating things to us is the fact that our His bundle recordings, intervals such as the HV interval at the end of the procedure, were of limited value for predicting delayed block. The negative predictive value is very high, 95%, for people with markedly prolonged HV intervals or AV Winkie-Bach at relatively long cycle lengths. But the sensitivity was no greater than 20 or 30%. And that, I think, is the other take-home message from this study, that there's more going on here than just the electrophysiology. I think these results tell us that people with markedly prolonged HV intervals have left conduction reserve, you might say. So if there are other insults, they're more vulnerable. But there's some other factor, such as inflammation, in response to the valve placement, that's playing a role, especially in the people that develop delayed block. And that really warrants further study.
Absolutely an incredibly important point, and I'm sure will be a ripe area for research for you both in the future. I want to thank you both so much for being with us. I'm Dr. Chris Patton, and I've been speaking with Drs. Al Buxton and Marie-France Poulin about the conduction disturbances after TAVR. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.